Thank you, Concorda, and I welcome this opportunity to update the House on the impact of COVID-19 on socially excluded groups and to outline the plans for administering the COVID-19 vaccine to these groups. Not everyone faces the same risk from COVID-19, and from the outside of the pandemic, the Department of Health identified socially excluded groups in congregated settings as having a heightened risk due to underlying health and social factors. The Health Protection Surveillance Centre, they provide weekly updates on outbreak among socially excluded groups in congregated settings. And since the start of the third wave, there have been 355 outbreaks in congregated settings. This represents less than 3% of all outbreaks in this period. There has been 3,863 cases associated with the 355 outbreaks. The largest share of the outbreaks is amongst the traveller community, who account for 3/4 of all outbreaks, 4/5 of all cases and 9 out of 10 hospitalisations. Regrettably, there have been 8 deaths amongst travellers associated with these outbreaks. The trend is reflected on the data for the last week, with 21 outbreaks and 112 associated cases amongst the traveller population. The incidence amongst other socially excluded groups is much less. In addiction services, there have been 10 outbreaks, 19 involving 60. In homeless services, there have been 24 outbreaks involving 163 cases. And among the Roma community, there have been 11 outbreaks with 72 cases. It is clear from the data that the impact of COVID-19 on homeless services and addiction services has been less than expected. This low incidence has been achieved by the actions of health and social care services in shielding the medically vulnerable homeless population. These services are saving lives, maybe not in hospitals, but by ensuring that people with underlying health conditions do not end up in intensive care in the first place. The long-term strategy for protecting socially excluded groups as well as other vulnerable people is through vaccination. The Government has agreed a vaccination allocation strategy that provides the provisional sequencing for groups to be vaccinated based on clinical priorities and ethical values. Importantly, disadvantaged socio-demographic groups who are more likely to experience a higher burden of infection and individuals at higher risk of COVID-19 due to medical professionals are prioritised in Group 9. There are others within the socially excluded groups who will get a higher priority due to underlying health conditions and those living in long-term care facilities, such as the long-term homeless accommodation. The numbers in these categories are small. For the homeless population, the total is circa 700 individuals. But it is critical that they are prioritised along with other high-risk groups. I know there has been a lot of focus on the age as a risk factor for COVID-19, and we need to be cautious in how we apply this criterion to socially excluded groups, for the simple reason that they experience premature onset of illness up to 20 years earlier as compared to the rest of the population. Furthermore, many of the people in these groups don't live to 60 or 65 years. I don't believe that we can be complacent about the on-paper prioritisation of socially excluded groups, because there may be of unintended barriers to equal access to the vaccine. And these barriers could include difficulties in attending designated vaccination centres, lack of contact with and trust in the health services, vaccine hesitancy due to lack of information, and low levels of literacy or language barriers. I am advocating a targeted campaign to reach vulnerable groups who otherwise may not have equal access to the vaccine, and advanced preparation before vaccine rollout is the key. Listening and engaging with vulnerable groups are critical to building confidence in the COVID-19 vaccination programme. Already the HSE has commenced its communications campaign with a series of webinars for service providers working with specific groups, travellers, Roma, migrants and residents in direct provision. And the purpose of the webinar is threefold: to provide information and guidance on the COVID-19 vaccination programme, including where to access trusted vaccination information, to answer queries about the COVID-19 vaccination programme, and to answer questions about the different COVID-19 vaccines. While considering the vaccination allocation strategy for vulnerable groups, we must be aware that this is contingent on the supply of the vaccine into the country. To conclude, COVID-19 has brought into focus the health inequalities faced by socially excluded groups, and it has demanded an intense and targeted public health response. Unfortunately, there are many second benefits for these measures in terms of easier access to services and adoption of an inclusion health approach based on individual care plans, interagency working and an emphasis on long-term solutions such as Housing First. I am determined that these benefits are captured within the health system, and to this end, the Department of Health has provided very significant additional resources to the HSE through its winter plan and service plan. Finally, I just look forward to hearing contributions of deputies on these matters.
Thank you, Minister.